gratitude to Professor Anderson for the very precise, nice presentation. I have honor to introduce distinguished professor of cardiology, Professor Marek, and his topic, tricuspid valve, learning from unknown.
Thank you, Natalia. In sake of time, I also concentrate on Epstein because this is my main research topic, and I should always mention the Victor Zank. We have probably the largest collection of the CON procedures in Europe, so we have done more than 130 CON procedures, and I'm very happy to share our experience. The few important issues is, and the first what I always keep quoting, and I don't have time to talk about the fetal Epsteins. The fetal Epsteins are amazing category as well. It's interesting because the maturity of the tricuspid valve lasts till third trimester. This is very unusual, and that's also why it brings such a large variation in morphology. The leaflets, in contrast of the mitral valve, are very thin, and this is for us, for the images. It's sometimes difficult really to image the tricuspid valve properly. It's difficult to identify the scallops, but we are quite good in identifying the hinge points. I'm going to skip this plastic valve, and I move directly to tricuspid valve. You have seen already this picture. So apart from the displacement of the septal leaflet, there is the rotation, and this is important because the rotation of the valve, it's giving you idea about how much of the right ventricle it's in the functional part, how much of the right ventricle is in the atrialized valve. So this is very important, and we use the measurement of the angulation, which is giving you some idea about the future and the outcome of CON procedure. I want to show you only this fetal and nearly adult Epstein heart, and actually this is what we are talking about. Is it about the valve or is it about the right ventricle? So if you see these two cases, if you measure the regurgitant fraction, it's almost certainly identical. And it doesn't matter whether you have the severe tricuspid regurgitation or less severe, the outcome can be completely different. Again, we have no time to discuss the neonatal Epstein, but if I just show you the outcomes and these cumulative survival rates, look at the data. Even in current era, survival rate of Epstein is only 63%. If you look at the fetal outcomes, they are quite poor. They are probably better compared to early stage, but many fetuses, they die even reaching the term because they develop the eye drops. And the patients may die even as adults. So very large variability with the very variable survival rates irrespective of treatment. But these are the mainly data prior to the CON procedure. So the imaging, we routinely use the echocardiography, MRI. I'm sure we will hear about the MRI more. These are the main projections. We love the subcostal view to look at the rotation of the anterior superior leaflet, four-chamber view, short axis view. These are the very important. And then we have the functional assessment of the right ventricle myocardium, left ventricle myocardium. 3D echo, I showed you a nice picture. This actually 3D TOE explains everything, and you understand where the problems stand. You see the sail of the anterior superior leaflet, then you can see the plastered small septal leaflet, and this is something people are not talking much the inferior leaflet is very often deficient, it's non-existent. And we have this experience based on the large data what we see. So now the question is it the right ventricle more important than the valve? If you look at the myocardium, there's no defined geometrical shape. Myofiber arrangement, it's completely irregular. There is a lot of the myocardial thickness, endocardial fibrostosis. It starts already in fetal age. There are the very good histological data from postmortem and the fetuses, and they confirm that the fibrosis actually starts very early in gestation. And when we look with the Andrew Cook and you use the little light, sometimes the atrialized right ventricle, it's paper thin. Jan Januszek, friend of mine, he believes that they are the myocytes, because now he's considering that maybe the patients would benefit from the biventricular stimulation. I am less optimistic because sometimes you don't see any myocardial layer. And in addition to it, there is a lot of non-compaction, and it's a genetic disorder. So the fibrosis, these are the data from MRI, looking at the endomyocardial fibrosis using the T1 mapping, and you see that more fibrosis you have, the poorer outcome. So it's very complex abnormality, valve and the myocardium. And this is what I told you about. Up to 39% of adult patients, they have the associated left-sided anomaly, and we know that there is this typical association of the LVNC mutation with the genetic disorder. Extreme Epstein's, they have the typical right ventricle dysfunction. We call it incompetent infundibulum. They may have normal pulmonary valve, but clinically presenting with the severe pulmonary regurgitation. And that's also very important in fetal age. So then many patients, you have this wash machine circulation because they have TR, they have the PR, and they have the open arterial duct. So this is why one of the options to treat the fetal Epstein is to commence on ibuprofen to reduce the size of the PDA. But again, unfortunately, I don't have time. So in fact, so if you look at this, so the physiology is almost restrictive, that the antegrade flow, it's driven by the right atrium, not by the right ventricle. And we all know that there is this funny septal motion, right? So always when you look at the Epstein, so you see, well, there is the very desynchronous septal motion. We look at that in detail, and actually what we found out that this is very interesting, because this part of the septum, it's partly fibrotic because septal leaflet, it's laminated or plastered, and then the atrialized ventricle interacts with the left ventricle. So there's the severe hemodynamic implication, because when the atrial contracts, with the delayed contraction of the right ventricle because of right bundle branch block, so then the septum shifts to the left because the left end diastolic pressure goes down. So this is the typical septal shift. And this has been also confirmed by the magnetic resonance. And of course, the broader QRS, more desynchronous ventricle it is. This is also why there is the theory that the patient who are not doing well after cone procedure may benefit from biventricular pacing. But this remains to be seen, really. So the cone procedure, and I'm sure we will hear more about that, is the relatively nice procedure because you don't use any prosthetic valve. Definitely the outcome is better than the prosthetic valve, and the surgeon actually detached the existing anterior leaflet, rotate it, and you're creating the cone. And if you use the 3D pictures, so then you can see the flow through the cone. so that it's giving you quite good idea how the inflow into the ventricle works. We published the first data already quite some time ago, and we were impressed by the technical aspect of the procedure. So there was, and it is really the very efficient technical procedure because you eliminate TR, you reduce the volume of the right atrium, you improve the clinical status, you improve the NIHA, you improve the exercise tolerance. So this is quite spectacular. But what you look at when you do the cone, and that's something what we all were very surprised, the right ventricle almost crushed. You do perfect surgery, but the right ventricle is not working, it's not contracting. So the idea is that actually the ventricle which was exposed to the high preload, we eliminate the preload and we increase the afterload for the myocardium, which is not prepared to do the work. But interestingly, because you eliminate tricuspid regurgitation, even if the right ventricle function is impaired, you still move the blood forward. So this is, you still fill the left ventricle. So this is why they perform better, because even the small energy in the right ventricle myocardium is very often enough to generate the good cardiac output. And when you look at the right ventricle function, you know, there is no surprise that whatever you use, the right ventricle function, it's down. The same in the MRI, but already look at the left ventricle before cone and after the cone, almost doubled in volume, right? So you move the blood forward through the lung circulation, of course, under condition that PVR it's low. So you help the patients. And for us, it's very important to see whether the right ventricle, whether there is the potential for remodulation. So this is all what we are waiting for, because the first cone procedure was done, I think, in 2007. So we still don't have the good long data. This is the one case. The right ventricle appears to be good, but you remember the right ventricle is exposed to a large volume. Now you do the cone, right ventricle is impaired, and 4 years later you see that the right ventricle is picking up. So it starts to contract, but even at 4 years after successful repair, still you would measure the right ventricle as impaired. We look at that and we confirm that measuring the TAPSE, that TAPSE is getting better if we compare the late to early post-op. And more importantly, and this is the one of the recent studies, we clearly see that the left heart is improving, and this is important because then you increase the stroke volume and you increase the cardiac output, and clinically the patients are getting better. They are also getting better synchronized when you look at the left ventricle and we look at the strain and the synchronicity index this is again our study, and the same was confirmed by colleagues from Boston using the MRI, that the synchronicity of the left ventricle was better. So to summarize, we believe that the cone reconstruction is reproducible, zero mortality, minimal morbidity. So it's a very efficient procedure. RV function remain concerned? Yes, does. Depends how much myocytes it's in the functional right ventricle. And the time now, and this is being discussed across the border, when to operate. So we have a successful operation, when to operate. Should we operate the asymptomatic patients? Symptomatic patients? Should we operate the patients with severe TR, moderate TR, mild TR? And the question is, if we do it in early stages, sooner, is there the potential for myocardial regeneration? We have heard about the proliferation of the myocytes. So I'll tell you at the end what the policy of Great Ormond Street is. we offer CON operation to completely asymptomatic Epstein's between age 3 and 7 with severe or moderate tricuspid regurgitation. So this is the current policy. So we believe that we are really changing the outcome of this difficult patient. Actually, going back to make a joke at the end, so Epstein was first described by Wilhelm Epstein, not by Jeffrey Epstein. Thank you.
Thank you very much. Yes.